All right, so I think then I'll probably move on to our next speaker. Dr. Peter Daley is an infectious diseases physician and a medical microbiologist. He's the Associate Professor of Medicine at the Memorial University. His internal medicine residency was completed at Queen's and Infectious Diseases Fellowship at the University of Calgary. He completed his diploma in tropical medicine and hygiene at the Gorgas Memorial Institute in Lima. And he went to medical microbiology fellowship training at McMaster University, where he completed a research fellowship in molecular mycobacteriology. Something I didn't know is that he lived and worked in India for 3 years as an infectious diseases training and research center at the Christian Medical College in Vellore, focusing on TB, and also completed a master's in clinical epidemiology at Memorial University, and his active research is in infectious diseases, including epidemiology, diagnostics, clinical trials, and stewardship. And he was awarded the Dean's Award in Research Excellence for junior faculty in 2016. I'm looking forward to his talk, leveraging digital solutions to tackle AMR. Thank you very much.
Thanks for the invite, and nice connection with the last talk from Yves Longtin regarding burden. I'm going to move into solutions. Let's talk about reducing AMR. Are there things that we can offer and consider as interventions? So leveraging digital solutions to tackle AMR, we're going to talk about some current and some future possible digital-based interventions that may lead to reduction in antimicrobial usage. See, we're on this constant cycle of a new drug that comes in, we use it widely among patients, the bacteria beat the drug, and we need another new drug, and we're just constantly cycling over and over again, when in fact we know that a lot of antibiotic use is inappropriate, unnecessary. And if we could only just reduce the use for a couple of key syndromes, for instance, the ambulatory patient with a viral upper respiratory tract infection, huge percentage of antibiotics gets used for that inappropriate indication. If we could just address that one syndrome, or secondly, the inappropriate use of asymptomatic bacteriuria therapy in long-term care facilities, these would be two ways we could significantly reduce antibiotic usage. So I'm going to talk a little bit about some of the tools that we have and some of the tools that I think we could consider having in the future to create a change in the way that we prescribe antimicrobials to humans. And Yves talked about AMR. Quick summary of this is AMR is increasing. So we have a pan-Canadian action plan on AMR, and yet we're still seeing worsening of many of the AMR pathogens. Maybe a few exceptions are on the decreased VRE, C. diff, but the vast majority of the news is continuously worsening. And we talk about addressing antimicrobial usage, we should talk fundamentally about usage in the community. That is, if you look at the percentage of usage that occurs within hospitals, it's a very small percentage. And although we are very vigilant in hospital and the ICU about stewardship and appropriate usage, we are only impacting a very small amount of total usage when we talk about the hospital. So our focus in our province in antimicrobial stewardship is more community-based. We want to see in a primary care setting, in an emergency room, in a telehealth interaction, that a prescription would not be delivered as opposed to the current practice. So let's focus my discussion on the community antimicrobial usage. Looking at rates of prescription in the community for antimicrobials in Canada, we saw a decrease during COVID-19. Unfortunately, that probably wasn't that the system got any better. It was probably more to do with lack of access or lack of diagnosis, lack of people getting to their family doctor, because after COVID-19, things have gone right back up to where we were before. In fact, some of us worry that they could even be increasing to what they were prior to COVID-19. So AMR is worsening, AMU is worsening, and we need to have some method to tear apart the good usage from the bad usage. And if you work clinically, you understand which of these syndromes do require an antibiotic and which of these syndromes do not. So if you are presenting with a pharyngitis, sinusitis, acute bronchitis, there would be absolutely no indication for an antibiotic. This is a viral condition. Even if it's a bacterial condition, which we can't always sort out, it's a self-limiting condition. So there's no indication for an antibiotic, and that's a huge amount of usage that we see inappropriately. Asymptomatic bacteria. Doctor, the patient has a positive urine culture. What antibiotic should I give? Does the patient have a urinary tract infection? I don't know. I just have a positive urine culture. Well, why don't you find out if it's a urinary tract infection based on symptoms, physical examination, before you determine that an antibiotic should be prescribed for a positive urine culture, especially in a frail elderly population. What about duration? We should give an antibiotic for the briefest possible duration, which generally speaking, for simple bacterial infections is 5 days. There's very, very rare indication to give an antibiotic for greater than 5 days. Endocarditis, osteomyelitis, very few complex syndromes, usually seen in hospital, usually seen by specialists. If you're prescribing in the community, why are you giving more than 5 days? Even in a long-term care facility, there really is no reason for longer duration. And if you must prescribe, can we give a narrow spectrum of activity that is focusing on the simple organisms, not the highly drug-resistant organisms? Again, I'm talking about the community setting. So these are the kind of things that we're trying to influence when we talk about antimicrobial stewardship in the community setting. And we have the Pan-Canadian Action Plan, which we're proud to develop. And it's been in place for about a year, and it's got these 5 pillars, and we talk about all these pillars within AMMI Canada, within provincial stewardship committees, within surveillance programs. I'm going to focus on the pillar of stewardship. Stewardship. Don't waste the precious resource that you have. Steward it. Keep it secure. Keep it for future use. Think about your children's needs. That's what stewardship means. And the Pan-Canadian Action Plan has made 2 recommendations for antimicrobial stewardship in Canada. One is the development of national guidelines for empiric prescription. And I'm going to tell you that that is underway with the collaboration between AMMI Canada, Public Health Agency, and First Line, the app that will be disseminating these guidelines. So we are we're started, we're maybe 4 syndromes in on a national antimicrobial use guideline, which has never existed in Canada before, and so that is progress to report. The other component of the stewardship pillar, if you want, is awareness, that is appetite. We need to demonstrate to patients that they do not need to request an antibiotic and that they can have alternative treatment available. Choosing Wisely is very big on this. If you're part of Choosing Wisely Canada, they have all kinds of excellent tools to influence therapy. Anyway, let's get into digital decision support. Digital decision support is one tool among many tools that we use in community antimicrobial stewardship. This is the CDC core elements of antimicrobial stewardship: commitment, policy, surveillance, and education. And among many tools, that is, this is not the only tool, we have decision support. What is decision support? Decision support is a point of care recommendation. Not that they call me in the hospital to discuss the case with me, but that something is available at the moment that the physician needs it to tip the argument between the physician and the patient. My child has otitis media. I really want an antibiotic. Yeah, but I have some decision support to strengthen me as the prescriber against the unnecessary prescription, and therefore I win the battle against the patient, if you want, and I do not prescribe the antibiotic. That's what decision support could be. So among these many other exciting tools, which we're also involved in, we'll talk about digital decision support. Now, what could it be? What it currently is an app, and the app contains local treatment guidelines. And the company that produces this in Canada is called First Line, and they're here with us. They are an app that we adopted within our province, and many other provinces have adopted. What is it really? It is supposed to be in the hand of the prescriber to help them make the treatment decision urgently. And it should be focused on not which antibiotic, but whether an antibiotic. That is, tipping the treatment towards no treatment or supportive treatment. Now, I'm invited because we studied this a bit in our province and what impact this app has had. But let me ask you this first. How would we measure that an app has been beneficial? And that comes to research design for evaluation of an intervention. And here are some things that we think we should be able to measure improvement with the use of an effective decision support tool. Certainly would be a reduction in antimicrobial use. That's fundamentally what we're after here. Secondly, would be something to do with appropriateness. Appropriateness is a word that we use for a drug that we're sometimes wondering if it's the right thing to give or not. We have appropriate indications and we have inappropriate indications. So then we should have some way of saying that the intervention has improved the appropriateness of prescribing. Not only the total prescribing, but the appropriateness of prescribing. And how do we measure appropriateness of prescribing? It's difficult to do. Some provinces have had some success with this. You need the indication for the prescription, and you need the prescription. So you need some data set that contains why did the doctor give the prescription. If it's written as acute bronchitis, you know it was inappropriate, and what prescription was given to the patient, duration, dose, and frequency. So that data is not available in our province. It may be available in other provinces. But we would love to think that a decision support tool would impact appropriateness. We have a measure of appropriateness for inpatients called NAPS, but we don't really have a good measurement of appropriateness or tool or assessment category for outpatients. It shouldn't be difficult to make. It's just difficult data to collect. We could measure that a tool was taken up. That is, our users are interested in it enough to start to use the tool. And we measure this in our province as numbers of engaged users. Which of the guidelines are the users opening up and reading? Do we have new users? Are we reaching our target population? And we should certainly, and we haven't done this, ask users, do you like this tool? Is it affecting your choices and your treatment behavior? Because we want to tailor a tool to the user opinion. And so we did a study, now this is back a few years ago, where we looked at the impact of the app in a before and after analysis. We brought this app into the province of Newfoundland and Labrador. We convinced the health system to pay for the subscription for the app using this data. Well, we said we saw a reduction in inpatient usage because that's really the only data we had to compare. Of course, not ideal. We would like to see reduction in outpatient usage, but we saw a reduction trend over the time of the study in inpatient usage, and then we measured appropriateness using the NAPS tool. If you're familiar with NAPS, it's a 1, 2, 3, 4, 5. Highly appropriate, marginal, not appropriate, highly inappropriate, and cannot determine. That's what NAPS says, and that's a measurement of appropriateness of usage. And we saw during the pre and post periods a nice statistically significant improvement in appropriateness of usage. Now, we're doing a lot of stewardship at this time. Can we say that the app was the only reason that we saw improvements in our stewardship indicators? Definitely not. This is correlation. So besides all the other stuff we're doing in the province, maybe the app had some contribution. Clearly, the implementation was associated, at least chronologically, with improvement. Excuse me. So now we go to our plan to create national therapeutic guidelines. You have been aware, if you've rotated as a resident or as a physician, different treatment guidelines have been available. Bugs and drugs, first line, pediatrics, they have theirs. There's a bunch of apps on your phone and you're wondering which one you should pull out for each of your treatment decision support. This is designed to be a single federal reference. It's never existed in Canada, and we're excited to follow the action plan's recommendation to produce this in Canada. And so this is being done between FAC and AMMI Canada, and we're starting with the WHO Essential Medicines list, which is all based on a grade level assessment of available data, systematic reviews. We are taking that data from WHO, we are contextualizing, we are updating, we are reviewing, and we are adopting or adapting recommendations made by WHO. So that is, we are countrifying the WHO overall recommendations. That is much less work than creating this ourselves from nothing, but we do think it is a rigorous assessment of available evidence. As we've been working through syndromes on meetings so far, we've been focusing on empiric therapy. That is, we're not talking about once we have culture, once we have surgery, once we have radiology. We're talking about empiric initial therapy, and we're talking about outpatient. So this is really about how to manage the ambulatory patient with empiric therapy appropriately. We talk about what other national guidelines have to recommend. We talk about benefits and harms, patient values and preferences, and we talk about resources available. And we also produce a strength of recommendation. But it's all designed to be presented in a way that's very clinically fast. When you're busy in the family practice and you've got 60 patients coming today, you want to open an app with minimal clicks and get a direct recommendation, amoxicillin or no amoxicillin. That's really what this is designed to do, because that's the vast majority of antimicrobial usage in Canada: primary care, telehealth, emergency rooms. We really want to impact that type of usage. Is this a tool for hospital use? Not directly, no. You may already have your first-line app for your hospital indications. Way more complicated. Look at susceptibility, look at toxicity, look at duration. That's really not the purpose of this national guidance recommendation. We want to target primary care. And First Line is the app that we're going to use to do it. I will go beyond what we're currently working into and start to talk a little bit about what we could do in this country as a decision support tool, future possibility. One is we could start to use the electronic medical record that's available in the community setting. You may have Epic or Meditech or whatever in your hospital, but in your community setting, our province, we have TELUS, EMR. Different provinces have different primary care EMRs. That EMR can be used for decision support. Maybe you're already doing this. This is fairly new in our province. The idea is the physician enters the data into the EMR, and the EMR provides tools at the point of decision to recommend certain therapies or not. And one of the tools that we've got in place is the classic Choosing Wisely viral prescription. Thanks for coming to see the doctor today. I'm going to write down on a little prescription pad my recommendations for you. Over-the-counter, symptomatic measures, no antibiotics, tender loving care, drink water, and take time off work. That's all what the viral prescription pad includes. A patient who likes to have a paper from their doctor's visit likes to have this type of thing, or if it's emailed to the patient or delivered to them in some way. What it says is, I care about your illness, and my recommendation is you will do well without an antibiotic. That's the viral prescription pad. Another, and in Public Health Ontario, they say that's associated with 75% reduction in antimicrobial prescription. The delayed prescription pad. Concerned about you, thanks for coming to clinic. I think your baby with otitis media is probably going to do well without antibiotics. But because you're nervous, and because you can't reach me 2 days from now, I'm going to write a prescription with the date for 2 days in the future. That's a delayed prescription. And the parent is very happy. Thank you, doctor. I appreciate that delayed prescription. I will not fill it because the pharmacist will not fill it on the wrong day. If I need it 2 days from now, I will fill the prescription, and guess what? It doesn't need to get filled because the baby's better. So a delayed prescription is an outpatient community-oriented tool that your electronic medical record can post. You're about to write the amoxicillin in the electronic medical record, and pop up comes this as a tool or recommendation for you to consider. Another tool that we like to use in stewardship is called audit and feedback. And that is a tool we use in hospital, but we don't traditionally use in community. Maybe we could implement an audit and feedback type strategy. How would that work? The computer reviews the data that you enter, and it may either stop you from prescribing, or it might make a recommendation, or at least it might give you feedback subsequently about your choices. That is a quality improvement intervention within the electronic medical record. It's a fairly automated structure. It's not meant to insult the doctor's independence, but it is meant to nudge the doctor towards appropriate usage. So an audit and feedback structure or a peer comparison structure. We noticed your antibiotic use last month. Here it is. Here's the antibiotic use of your peers. Yours a little higher than your peers is. Maybe you should modify your therapy based on peer comparison. These are all tools that the electronic medical record may bring us into. But even further, maybe we have some digital pre-authorization. Then that becomes more of a permission, more of a regulatory intervention. Sorry, you cannot have that prescription for that patient according to an algorithm or a pre-established rule. And we need something that makes it difficult for the primary care provider to give the wrong therapy and makes it easy for the primary care provider to give the right therapy. And we have models in different quality improvement ways that have done this. We definitely don't want to add to the primary care paper burden. If the primary care provider needs to fill out one more form, they will lose it. They really don't appreciate that. So it's got to be a tool that actually steers the behavior towards the appropriate treatment without adding burden. And I'm not sure what the answer is exactly to that, but I think we have models in this country for regulation or control of certain substances such as narcotics. Maybe we need to learn from that in the way that we might deliver antibiotic stewardship. So I'll wrap up there. I've given you some progress report. We have achieved at least one of the recommendations of the Pan-Canadian Action Plan in developing the national treatment guidelines. And we have ways like a first-line app that can provide digital decision support at the point of care. Maybe we can take this further into new ideas in the future. Let me wrap up there, and we can take some questions if Philippe wants.
Thank you very much, Dr. Daley. I think we've got some time for some questions, so if people want to either come up to the microphones, we've got a couple in the room, and online there may be some questions as well.
Dr. Daley, one of the things that our sepsis survivors tell us is that I went repeatedly to the emergency department and nobody listened to me and I was getting worse. Where is the balance in all of this? And I was just looking at your prescription there. I would say two things. We know evidence that people who are septic don't always mount a fever. They may in fact be hypothermic. And there are some specific signs and symptoms that I would want them to return to an emergency department and somebody to listen to them. And then finally, what do we do with that viral sepsis? I realize it's rarer, but it does occur, particularly in the elderly, where, you know, I really want them to be in hospital because I need to monitor their oxygenation a little more carefully for, you know, influenza. We've had deaths due to influenza in this country. So where's the balance in all of this?
Certainly in the emergency room, that is the critical moment where we're deciding the patient is sick or not sick. Most of my comments, I would say, are focused on the family practice or the primary care setting or the telehealth setting. You're absolutely right. In the emergency room setting, we have to make a careful, and it's a difficult decision, that this is early sepsis or this is a mild self-limiting illness. In stewardship and you working in ICU, I'm quite happy to have a patient admitted. I'm quite happy to have a patient initiated on broad-spectrum antibiotic therapy. That is, the upfront urgency is taken care of. Come day 3, I want a really good evaluation of whether that patient really does have sepsis. That is, once we have microbiology, once we have surgery if needed, once we have radiology, then come day 3 we say, oh, turns out this was all pancreatitis and we should treat without an antibiotic, right? So, of course you're right, we have to be careful in under-treating. At the moment in Canada, in primary care, we are way on the side of over-treating. So we have a long way to go before we start neglecting our patients or seeing them die from under antibiotic therapy in primary care, I feel. Thank you, that's a good question.
Hello, I have a question about the implementation of the app. You're speaking about use for primary care to support general practitioners or family doctors, but are there any plans to support pharmacists in the pharmacies. I know last year during our symposium, there was a huge call from the pharmacists themselves for education as well as support in this way.
I think first of all, our app is freely available to all pharmacists, so it's definitely not restricted to nurses or physicians. It's a pharmacist. The patient themselves can log onto the app and read the guidelines. The pharmacist is more and more the prescriber in primary care, and we're delegating care more and more to the pharmacist. So in fact, we generally see that the pharmacist uses antibiotics way more carefully than the physician does. I would rather have the pharmacist be the choice in terms of the prescriber. So strongly encourage pharmacist prescription, certainly for simple syndromes, not for patients admitted to hospital probably, but for primary care. I really think the pharmacist should be making the decision. And the app is any provider. It's not specific to any one group.
Okay, I think we'll move to some of the online questions for a minute. Does Alberta use this First Line app? I've never heard of it, though I am not a primary care physician. I don't know if you can answer that.
Maybe Mike can tell us. Is Alberta using First Line? Calgary Zone is, yep. So First Line is an app that's progressively spreading across the country. It's a company based in Vancouver, and different provinces have different levels of uptake, but certainly available within Alberta.
Go ahead on the left.
Hi there. I'm wondering if now that we have the hopes of a national pharmacare and CDA AMC is working on those efforts, is there alignment between your efforts with respect to antimicrobials and this sort of guidelines and what CDA is doing in their efforts towards a list of medications that will be and should be funded?
I don't know the answer to that question. I would say payment and cost and access is not usually a big impediment in first-line antibiotic therapy, which is amoxicillin and trimethoprim sulfa. So I'm not aware that AMMI Canada is specifically looking at that in terms of the national pharmacare strategy, but I do say that cost is not usually a big factor.
And there's another online question. How can we tackle overprescription of antibiotics in primary care, especially from the perspective of a family medicine practice? And I think you've talked about some of these strategies.
Yeah, thanks for the question. Exactly the purpose of the talk is changing that interaction between the physician or the prescriber and the patient and tipping it towards not prescribing. You know, we provide all kinds of these tools that I've shown, the viral prescription pad, the delayed prescription pad. Put something up in your waiting room from Choosing Wisely Canada that says, no amount of antibiotics will help you with your cold or your flu or your adenovirus RSV. Lots of other tool ideas. Can we provide point-of-care diagnostics to separate a viral infection from a bacterial infection? I really hope that's coming in the near future. Some of the tools.
Go ahead.
Hi. So perhaps a naive question from someone with no clinical background, but do you think like the reason for the overprescription and let's say inappropriate prescription of antibiotics is in the lack of education perhaps of clinicians, or do you think it's rooted in problems with our healthcare system like inefficient diagnostic methods, so it's safer to preemptively prescribe antibiotics or short doctor visits, etc.?
Yes, yes, and yes. These are all the challenges. We often say in our provincial stewardship committee, are we blaming the provider or are we blaming the patient? Who should we educate the more, the patient or the provider? And the answer is yes, yes, yes. We have to intervene at all these different levels. We have patients in our province that are very, very, very hungry for antibiotics. They're not happy unless they leave the clinic with the prescription. In fact, they will go to another doctor in order to get the prescription that they seek. So that's clearly an appetite problem if they have a benign syndrome. But we also have physicians in our province that are on the extreme high end of prescription rate. Prescriptions per visit are 3 times higher than other providers. Clearly, that's a prescriber problem. So we have to try to address all of those things.
I do have my own question. Are you familiar with any of these apps that might be starting to use artificial intelligence to try to assist in diagnosis and prescribing practices?
I don't have any experience with that, although it sounds exciting. I mean, if it's correct, it sounds like a nice option. We struggle, and I don't work in primary care, but I've done plenty of that in looking at the patient and trying to decide this is a virus or this is a bacteria. If we had some tool that could say, scan the patient or examine the patient or enter the patient's data and make an assessment as viral versus bacterial, I think that's going to be very hard to do because these are overlapping syndromes. If you have these respiratory tract symptoms, it's very hard for me, or I think probably for AI, to sort out who's got a virus and who's got a bacteria. We need a biomarker, and it needs to be at the point of care, and it needs to be cheap. And that's what we would like.
Thanks for the great discussion. I was asking a question more about hospital antibiotic stewardship, which is where I think we see the greatest resistance and the impact of resistance on patient care. Isn't there a real challenge in even getting consensus in practice, say amongst a number of infectious disease specialists like myself, like to actually agree on what a duration of therapy should be? Like, I agree with you, 3 days in the ICU on therapy, that's fine. But what about after that? How long do we treat for? And we often agree on 7 or 10 or 14 days with really good evidence. And isn't the first challenge even getting a consensus that the specialists themselves, who are the leaders, the lead prescribers, can agree on? And the second comment is, are we underusing the biomarkers that are available in their infancy phase, be it procalcitonin, in hospital environments in Canada compared to what happens in Europe or the rest of the world?
I think it's very tough to get consensus. Where evidence is clear, usually consensus is better. In antibiotic use, sadly, we don't have the kind of level of evidence that we want. I think that is a problem in hospital where let's just wait till the next ID comes on next week so we can change the opinion about how we should use the antibiotics. So I concur that there's a consensus problem. Biomarkers, I think we underuse. I think procalcitonin has specificity for bacterial infection. I think procalcitonin has prognostic ability. So I've been asking for procalcitonin. I haven't gotten funding for it, but I do think that's a useful tool. Or we can develop better biomarkers than procalcitonin.
Right, and a final question.
Yes, thank you for your presentation. My question is if you have been able to measure the levels of resistance next to the implementation of the application, and if you have seen an increase or reduction of the resistance? Thank you.
The holy grail of all this is to drive antimicrobial resistance down. That's what we're trying to achieve. We don't have good provincial level representative antibiogram data to report on that. I would like to say, though, that when we're talking about antibiogram, that is resistance among clinical isolates, we are not really representing the resistance problem. That is, if a patient becomes sick and has a positive culture and is identified as a drug-resistant pathogen, that becomes the data point. But what about all the other patients who don't have a culture, all the other patients who are walking around with AMR among the flora, transmitting AMR between animals, humans, and environment? We don't have a good measurement for that. So the only tool we really have is hospital-based, microbiology-based culture antibiograms, and that's something. But I really think we miss a lot of what's truly happening unless we start to dive into the flora and uncover the metagenomics. What gene is the patient carrying today? What gene is the patient carrying the next day? We don't do this type of work because it's very expensive and it's very slow. But that really is a better assessment of what's in the flora.